Here we go. Okay, so welcome everybody to our second monthly webinar series on regulatory excellence. And can everybody see the screen? At least the cover page of that that's showing up.
Yep, it's there.
Okay, excellent. All right, it's great when those things work. The added feature of it being tariff-free, not a common thing these days, but we're going to focus on regulatory problem solving and sort of working upstream, which we'll explain very shortly. So the goal here is to talk about why and how to start upstreaming solutions to prevent or reduce, let's be realistic sometimes about regulatory problems. We will, of course, be recording this, and the slides will be shared with all participants, and we're going to be making it available on our website as well as for access that way. And we're going to be opening that up as well in terms of it's on a YouTube channel that will be published shortly. So not to take any copious notes, a little bit about our organization. We're a consulting firm focused on public sector, really focusing in 5 particular content areas around policy, research, development, analysis, user experience, learning and development for employees, as well as boards and volunteers, and strategic planning, as well as engagement with stakeholder partners. You can see it produces the lovely acronym of PULSE. And we are always looking to think about sort of more upstream solutions to get more prevention. And one of the things that we're offering for a time is a pulse check. And this is really sort of getting a sense of your organization's current capacity or maturity level when it comes to these 5 particular domains. So it's a free 1-hour consultation, and basically you get a report out of that gives some indications around where we might want to investigate. A wee bit about me. I have just finished up with 20 years of experience with Professional Engineers Ontario, where I was involved as a policy manager. Also dealt heavily with strategy and governance, as well as continued professional development, professional practice issues. So covering a fair bit of the gamut of the regulatory regime there for regulated professions. Prior to that, I was with the Ontario government in Ministry of Community Social Services and a secondment at Ontario Cabinet Office. So I got to see decision making all the way up to this food chain and what goes in there. And while I was with PEO, one of the things that I started up was a regulators policy network across all of the 40 some odd regulated professions in Ontario, trying to share best practices to really hopefully raise the bar across things and just basically to get people connected to each other. So let's focus and the way I had structured this presentation was really about what are the biggest regulatory problems from a regulated perspective, but I think we can probably expand that concept to whatever an organization is typically dealing with. In terms of regulated professions, typically they are dealing, one of their main headaches is the complaints that come in, and these aren't complaints against the regulator, these are complaints that are filed against a practitioner by a client, a patient, etc. And those are legitimate complaints. They need to be investigated and addressed and resolved, but there's very little control in terms of the volume, in terms of the how long it takes to dispose of those cases, what are the types of issues that come forward, and because there is legal representation on both sides, so it can quickly add up to a significant amount of legal costs. So as an issue here coming in, you don't have much control over it, but you're certainly dealing with that. And on somewhat lesser scale, issues with people who are applying to be qualified as a practitioner. So are there failure rates when they have to write exams or on their applications? Are these things that, um, give us headaches? And then further down the path, once someone has been licensed or registered, issues, the concerns we have with non-compliance. So it can be professional practice standards and guidelines. It can be continuing professional development, annual reporting requirements for the regulator or to the regulator, and quality assurance measures or practice reviews. We also, one of the things from a governance perspective we often have is challenges with our committees or our boards, in terms of the agendas that they present, and there's perspectives and mandates and priorities, as well as sort of how they make decisions. And ultimately, when you look at those problems, it's a question of ultimately, you've got to deal with it. And when they happen on a repeated basis, you can continue to just sort of take it, or you can actually say, what would it take to actually make this problem disappear? How can we prevent it if it didn't happen in the first place? So there are a few sources of, where this has come from, in terms of issues and ideas. One of the formative ones in at least the regulatory space is work by the Professional Standards Authority, which is based in the UK, and that work has kind of gone more international. They have a concept called right touch regulation, which is essentially, and I'm oversimplifying it, but it's essentially a proportionate response, a proportionate level of intervention or response by a regulator proportionate to the risk that is posed to the public. So you've got to first determine what the risk is. You've got to be able to quantify it and assess its likelihood and its impact, and then look at what's an appropriate level of intervention within your mandate. So some of the things that they were looking at, and they've continued to look at for many years, are issues about, after the fact, dealing with complaints and quality assurance. How can you, as a regulator, can you get that information? Can you share the knowledge with agencies? What can you do to encourage potential informants or registrants to be able to take preventative action around risk to harm to patients? How do you support the public in terms of raising concerns, raising issues of something they think isn't right going on within the system or with their practitioner? And ultimately, we want to be able to target the responses. We want to be able to say that these things connect, that we're actually, if we're taking interventions, they need to connect with a certain amount of, what are the kinds of issues that show up in complaints? What kind of data do we actually have? And they've done a fair bit of work, as I say, over the last decade, especially on looking at avoiding harm and looking at providing more data to support those insights, coming up with more targeted approaches to regulatory solutions by identifying higher risk groups or situations. Could be workplace types, could be a number of demographic factors, and trying to actually work with those individuals who do come through complaints to sort of reflect on retrospectively what could they have done, to indicate sort of where were the early warning signs perhaps that we can begin to investigate, and understanding as well the relationships between regulators and their registrants, meaning the practitioners, and how those things can influence what gets done or not get done. What is that nature of that relationship? What's the role of the employer or the workplace that often has its own requirements, its own standards, procedures, etc., and that imposes and creates certain incentives or disincentives of behavior. And finally, looking at what is the role of the patient in care. Can they be, empowered in a way to be aware of what they should be expecting or critically assessing this is not something that I'm happy with. A second source, a little more in the popular literature and less in the academic and regulatory realm, is a book came out about just after the pandemic, I think, 2020, if I'm not mistaken, 2021, by Dan Heath, and it's gotten a certain amount of it, and there's while the ideas are not dramatically new, he sort of popularized in terms of putting things together in ways that really, I think, better encapsulate sort of the model and the thinking that needs to go on. And as we'll see, there are lots of examples. So one of the ones that comes up that is a public health parable, it may get quoted a bit. It's attributed to Irving Zola, but here it goes. Basically, as the picture would illustrate, you and a friend are sitting by the riverbank, and you are having a nice picnic, and all of a sudden you hear the sounds of trouble. A child is drowning, and you're able to intervene and rescue that child and bring them to the shore. And no sooner do you manage to do that, but you start to notice there's another one. You hear another and another and another, and you and your friend are now frantically involved in pulling children out of the water to prevent them from drowning. And at some point, this just keeps going on, and your friend gets up and says, I'm going. He says, where are you going? He says, I'm actually going upstream. I want to go and find out who's throwing those children in the water or why those children are in the water. So he's actually taking the approach to see if we can't prevent these things from happening in the first place. Something that comes up a lot in the health field, I guess, in social work areas around social and health determinants, is a way of sort of distinguishing the upstream, midstream, and downstream effects. So if we start from the bottom working up, the downstream is really where we're talking primarily about clinical care, treatment, medical interventions, or any other kinds of interventions, but at least in the health realm, this is what we're talking about. As you go midstream, you're looking at matters of how can we actually, if we can't necessarily prevent, can we have early warning? Can we have screening? Can we have certain things that we're going to pick up perhaps on the way to address? We're not really solving the problem, but we're at least sort of picking it up earlier. So all kinds of screenings, and if you are going for regular dental checkups and you're going for medical checkups, or if you were taking your car in for regular maintenance, all these things are part of sort of screening, that there are things that are kind of expected that could be happening with age or other factors, and you want to at least try and catch them a little bit earlier. If you go further upstream, then you're looking at what's the original source of this. Where are the individuals that are involved or systems that are creating some of these problems? Some of them may be laws and policies and regulations. Some of them may be other intervening factors of poverty, of health, of certain decisions that people make, life decisions that can heavily influence those kinds of directions. So these are all very much important. So just to get the terminology in terms of upstream, midstream, and downstream. What upstream thinking is about detecting problems before they occur, is being more preventative and proactive, risk-based, focusing on the early warning signs. It needs a systems level kind of thinking to look much more expansively. And doing so, we come up with solutions. They tend to be broader and slower, but they tend to be having much longer lasting effects. And as always, it's a goal, it's a direction. And sometimes what's practical is you can only go certain part upstream or midstream based on resources and more direct effects. Ideally, you can always keep going up, and then should be a sort of a continual thing. Some quick examples that I think most people are familiar with. Maybe we don't think about how those things came about. But clearly, in the personal health, personal safety kinds of realm and in construction, you typically have a number of um, things that are there. Some are more um, like car seats and seat belts and helmets are clearly things that are intended to be much more at the upstream level. Other things are more screening when we talk about criminal background checks, or we talk about the surgical checklist, a pre-surgery checklist that was actually produced in Boston based on medical data that indicated where the morbidities or where things went wrong in surgery that could have been prevented by a simple checklist. So a whole bunch of these things are, definitely part of the puzzle of trying to intervene, and they can be services and they can be products to do these things. And this is just meant to be a sort of a quick example. So if you look at the pills, for example, right, a lot of seniors especially have a lot of medications that they have to take. Can be multiple medications, can be several times over a day or at least on a daily basis. And to be able to know to make sure that you actually have taken your medication. So having that pill dispenser labeled by day was a brilliant idea that someone came up with to at least force the reminder, at least have something to be able to do it. And we can, of course, go much more automated these days with all kinds of sensors and alerts and warnings. Let's take an example from the book, Upstream book, which was dealing with Chicago's public schools and high school area. In 1998, they had a 52% graduation rate, and it seemed to be accepted by the administration, by the school board as well. That's just the way it is in these particular areas. There are all kinds of demographic, social, economic factors. And we do the best we can with the kids coming through, but we really can't have any impact on that. And there was a small group of teachers who decided, you know what, let's see what we can actually do about this. And they began by really sort of owning the problem, saying, okay, what is the stuff we probably can't deal with everything on the socioeconomic and the other demographic factors, but in fact, let's focus on what we can do within the school system. And when they looked at the data around who graduated and who didn't graduate, and they sort of traced it back, they found that there was a very strong correlation in the first year, especially the first semesters, students' performance, and ultimately, did they end up graduating? So the ones who ran into difficulties early on got to, discouraged if they fell behind, they gave up, and usually very early on they had either dropped out or barely sort of squeaked by the system. So they looked at the research to use this as an sort of an insight as to where they could intervene, what made the most sense, and they actually adapted it to actually put the best teachers to actually work with the first year students to keep them on track, to be able to have earlier kind of interventions, earlier approaches that would make sure they don't fall behind, that someone's checking on them in terms of attendance and how they're doing, and a much more intensive work. So fast forward 20 years later, we're actually looking at a significant 25% increase in the graduation rate based on those kinds of interventions. So just one example of what can be done. When we come to our, I jumped in. Okay. So yes, so we definitely want to put ourselves in a certain mindset. Says we're not going to accept the problem as it is. We're not going to accept these things as just normal. Taking a more strategic approach that says, no, we actually want to do something about this. We've got to own it. The portion of it, at least, that is ours, or we're going to try and influence. These things are often very complicated systems. And we want to avoid focusing on sort of the obvious choices or solutions, or giving up on it and saying, it's just too much work to be able to turn these things around. When we talk about the regulatory space in terms of life cycle, we can see at the far end what we call the sort of the downstream areas of dealing with complaints or discipline matters. And as we work sort of further back up, there are different parts of a regulatory regime that would suggest where we can perhaps move upstream to look at that. So quality assurance practice reviews come in, annual reporting and CPD, professional practice issues. What happens when someone is licensed? What kind of onboarding, what kind of setup are they doing? And finally, even at the student or the experiential acquisition end, that's something that we definitely want to look at potentially. So can we better prepare our students for these things, knowing what these things are? And the premise is that it's far easier to start off with good habits and try and get good habits. So you think about this with children. It's a lot harder to do it afterwards, to change when someone's gotten into some negative habits or some lazy habits of things. It's a lot harder to change that. So if you can have a higher intervention at an earlier stage, and then it may take a long time to benefit, but you're going to ultimately see that. I'm going to skip the poll because we've just got a small number, and that would be kind of a meaningless statistic. One example from the Law Society of Ontario, where they just rolled out this year a new mandatory course for anybody who wants to either be or is a new sole practitioner. And they did this on the basis of looking at their complaints coming in. What are the types of issues? So there's a higher proportion of complaints filed against sole practitioners, sole proprietors. And typically these are, either people who are, just out of law school, and it could be, or a certain period of time of people who decide to go out on their own, but they may not be as experienced with understanding the ins and outs of running the business and some of the challenges that go there. So they focused on what's the content, what are the problems that actually are more likely to result in complaints. And now they said, well, we're going to now have a mandatory training course. Everyone has to pass it in order to continue to operate as a sole proprietor, as a sole practitioner. And if you don't do that within, in this case, 2 years, complete the 30 hours of course, then you're going to have an administrative suspension, which prohibits you from practicing. So it's got a significant sanction effect, but it's a good example of what's going on. So in terms of getting started in upstream thinking, so we have to start with identifying and quantifying the problem, looking at it within a system or a chain. That's really the critical part. It's easy to sort of focus just narrowly about what's the problem and to not look in the context of which it occurs. So understanding and looking at, sometimes how do we know that it's a problem? Are we looking at errors? Are we even near misses of things that we should have caught? And why we did catch, but just barely. Understanding why and how it's a problem for whom. You can use something called the 5 whys. You just keep asking repeatedly, why do we do X, or why is this a problem, et cetera, et cetera. And it takes you further back to more of the core issue. What's that actual impact? What is it costing you? Is it dollars? Is it time? Is it human resources? Is it you have to spend your time now in crisis response, which is a high risk, high threat kind of situation that's usually you want to avoid. But if you're going to always be spending your time in crisis, then you should be looking at it and saying, how do we start to prevent some of these crises from emerging? Understanding in the system, who does it involve? Who is both acting upon and who gets impacted by it? Understanding, is there a pattern to these things? Where and when and how does the problem actually happen? Is it a Was this a one-off thing? Is this something that is repeated? And we're looking at the data for patterns or correlations. Ultimately, as well, we're looking at an indication of, okay, who actually has responsibility for this problem? And sometimes we find in organizations that the problem is distributed, so much so between different departments, different units, that nobody's looking collectively at the issue and say, you know what, this is a larger problem that sort of falls below or within the silos. In terms of getting started, so finding people who actually want to own and solve this problem, modeling it within a system to understand the sequences and the behaviors and decisions that happen, using experience research around users to understand their behaviors, incentives, disincentives, and their decisions, understanding potentially what there are leverage points or actors that we can use. We have to be able to prioritize where the leverage is going to have the biggest impact and at what particular stage. What do we think is going to do that? One way to sort of test out a few hunches or options is to do randomized controlled trials or do A/B testing in the same populations, but different areas, to test out different interventions here and pilot those kind of interventions rather than trying to go all in, but ultimately evaluate the results and scale up. We want to make sure that when we are measuring it, the problem is that it's very hard to measure stuff that hasn't happened. And so defining the outcomes of what you're expecting, an increase or a decrease in something at different stages is a first step here. Understanding not only how you're going to measure it, but what qualifies. Want to make sure that you're not over or under reporting things. Who's going to measure it? Who's going to report it? Is there any subjectivity, interpretation questions that come up? As I mentioned, doing randomized trials or A/B tests to be able to compare different situations, to be able to say, okay, now we can say when we did this intervention, we had a whatever X% increase or decrease in Y. And if there were no other factors, then we can attribute it and say that's because of this particular intervention. We want to be able to as well look at early warning indicators and be aware that sometimes if people have other options as to where they can avoid an intervention and go elsewhere, go to the next neighborhood, go to the next county, or somewhere else. So you get some leakage of the system. So you can't assume that it's there. So some of the things that we worry about in terms of data, because of course, what gets measured gets managed, as Peter Drucker says. So you can either, have the problem where you're succeeding, but you've actually attributed that success to your own work. So if you think about a baseball team, for example, it hits more home runs and it's rewarded for that, but it could be that every other team is hitting more home runs as well. Pitching talent is declining, people are getting stronger, etc. So it's not necessarily attributed to your work. Or it could be that you've focused on the short-term measures which didn't align with your long-term ones. So great, you scored more home runs, to continue the baseball analogy, but you didn't actually win any more games. So are you being rewarded for just hitting home runs, or are you being rewarded for ultimately winning games? And be aware of things that can undermine it. Things can maybe even counter it. So, as an example with baseball, again, the pressure to hit home runs can lead several players to start taking steroids, and then they got caught. So it creates these other perverse incentives, or you've underestimated their ability to go elsewhere to avoid the particular intervention. We want to try and make use of early warning signs and interventions to be able to identify the problem. We want to make sure, of course, that we're not, if we're going to get false positives, that we're not getting fatigued by that to ignore them, and have to decide how many you know, what rate of false positives do we want to accept in that realm? One little story came out of the book as well, unintended consequences, which is something you have to be aware of. So this was in San Diego, California in 2017. There was an outbreak of hepatitis A that was some were contributing to the lack of plastic bags. So how does this, what's the connection on this? So the city had, from an environmental standpoint, had decided to ban plastic bags. And they also happen to have a significant population of homeless people who, it turned out when they investigated a little bit more, well, these folks had been using the bags to dispose of their own waste. And when the bags were in more short supply, people turned to use, you know, other less sanitary means, and ended up with hepatitis A, which is clearly a much bigger health risk than the one they were looking at just for plastic bags. We're going to skip. We had a nice case study, but we're going to skip that. And I want to we'll just go down here, go to a summary here, and then we'll sort of open up for questions here. So we can see that upstream thinking is a fairly powerful tool to avoid or mitigate downstream repeated problems. It requires a more systems mindset and clarity on the source of the problem, the actors, behavioral decisions. That's where user experience comes in. You need to test out those solutions as possibilities first in piloting them to avoid the measurement error problems or unintended consequences. And when you're dealing with human beings, of course, they are not as predictable as machines and always repeatable. There can be a fatiguing effect. There can be habituation, and that can cause a decline in the stats over time. It's very critical to understand how much control or capture you have, how much enforcement you have to actually get consistency on that, and to be able to critically measure that success. So if someone has the ability to, they don't have to go through that. It's an optional approach, an optional intervention. So depending how you market it, you're only going to get a certain percentage of people who go through that. The more and more that you have control and enforcement, you're going to increase those levels. And solutions can be designed at early, you know, the earlier previous stage. You can still sort of start from that midstream or a little bit further up of where those occurrences happen, and you can keep working iteratively backstream or you know, sort of backwards or upstream on that. And it's important to set up those early warning sensors. And a question I wanted to ponder and maybe open this as a good discussion, which is regulatory bodies, of course, regulate practitioners. And those practitioners are, you know, predominantly they're treating, they're providing therapy, they're providing a service to someone who already has a particular issue, problem, whatever it happens to be, whether it's legal, whether it's medical, whether it's social, whatever those things happen to be. Ultimately, is the system focused on just practitioners? They get paid for treating or providing therapy, but do they get paid for preventing those problems? Is that an appropriate role for a regulator or who owns this sort of larger problem? And recognizing that, you know, I think a lot of our, certainly our health systems are geared to treatment. They're geared to, and get what gets paid is the treatment, the downstream. So what kind of measures or opportunities might there be to change some of the funding, the behavior to promote, or what would it take to promote a more preventative approach? So why don't we hold up there, and I guess we can open it up
No, thank you. That was really interesting.
Okay, so you work in the health space. So what's the word in terms of prevention and trying to the systems, are they heavily weighted to treatment, to therapy, to downstream effects, and how do we sort of move that needle?
So it's interesting because I don't work. Okay, it keeps muting me. Jordan, can you turn off your share and then I can see you and then
Okay.
yes, then we can
Okay.
actually have a conversation when it's just the two of us. Fantastic. It's interesting. The questions are really interesting. I think I'm not in the regulatory space, so I have less to say about that in terms of problems or solutions, but I am familiar with upstream solutions in healthcare in terms of looking at population health and how um, research engagement and engagement from primary care at a population level can be um, the driving forward solution, as well as looking at the system from a learning health system perspective. So taking into consideration data, evidence, and varying forms of evidence, not just data itself, but interpersonal, interprofessional conversation, and other and clinical trial results. Um, all have an important impact on policy decision making and on clinical decision making and the interfaces between them. So, an interesting way to think about those upstream solutions and perspectives and where they fit in. Um, yeah.
I mean, it gets fuzzier when the broader you go, to look at social determinants, and the money just sort of dissipates when you start talking about certain interventions of, better health. So you can do health promotion, you can talk about the importance of diet, you can talk about the importance of, uh, of exercise, you can talk about, healthier lifestyles, right? You can do all kinds of government advertising and promotion. Um, but it's very diffuse in terms of impact. So what I'm thinking is, at the level when people have um, interactions with their health providers, are they, is there a way to insert more prevention and thoughts of prevention on, at that sort of initial stage, and healthcare providers, and they're paid to on a per, at least the GPs are, and those who aren't on a salary are paid on a per procedure basis. So, simple economics would say they're going to maximize the number of procedures to a point where they don't want to do any more. And they may lean towards the ones that are either more costly to justify their time, or maybe they do lots of smaller things but they have to do a lot more volume. So when you have a consult with a doctor and you want to just talk about in general health, promotion issues here, then they get a certain amount for a broad sort of consultation. They get a lot more when they're actually treating you for something. And I know didn't Quebec go to a model where they, instead of paying physicians anyways on a per procedure basis, they basically went to a kind of per patient model, if I'm not mistaken.
I'm not sure. I know that there are some jurisdictions that have that model as compared to others, so but I'm not certain
Yeah.
precisely. But to your question, I think it's an interesting thing because I think that creates that necessitates a culture shift of how the individual also uses the health system. People go to their doctor when they want to be treated for something. The exception that I can think about with that would be maternal health care, in which there is quite a number of reasons to go to a physician for preventative care, and in managing health from a prevention perspective as opposed to a treatment perspective. But I think that is fewer and further in between of how individuals use the health system. And for the most part, you are going to your physician for treatment purposes rather than prevention purposes. And where prevention is on the table becomes dependent on individual health markers and what one can offer within the current evidence of health treatment.
I mean, it could also be an issue that they may not be as knowledgeable about health prevention issues to be able to give the advice. They may not be trained in it. They may not have the resources. And, they may be less, patients may be less receptive for it. I'm coming here looking for treatment. I'm looking for a prescription. I want to come away with a prescription to feel, that I've been successful in having my issue addressed. I get some diagnosis, I get something to walk away with, but as opposed to, here's more advice for me, thanks very much, I've got to do this or not do that. So when you look at the Quebec model, where patients, physicians are paid on a basis presumably of outcomes. So you've got X number of patients in your practice and you're being paid an annual amount. One would think on one level that the physician is going to try to ideally sort of maximize the value they want. They might bring in more preventative aspects to avoid some of the other pernicious things that they end up seeing, where those things can be prevented. On the other hand, patients look at that as kind of a blank check. It's like, I can go to my doctor as often as I want, and it may actually be counterproductive. Because, as I say, this the economic aspect of trying to maximize value. But I think, having the data, at least as you mentioned on the maternal health, to be able to prove that when we did these kinds of early treatment or early preventative approaches, or screening is good, you're going to catch stuff earlier, but just setting people up for healthier pregnancies, how does that compare in terms of the return on investment? We've spent, those visits, and we, get fewer negative aspects showing up, and to be able to prove that to the policymakers, to the funders, and say, do we need to move to, more preventative approaches? It's interesting. It happens in certain domains more easily than others. So in construction industry, although you have issues with compliance, but you have you have hard hats, and you have steel-toed boots, and you have procedures and protocols that need to get followed, that sometimes are not. And that's where accidents happen. So they base it on the data, and they say, look, therefore we need to have mandatory requirements for doing this or not doing that. And it'd be interesting to see, some auto insurance companies now have put in place monitoring systems to monitor how you're driving, how smooth is your driving, what are you constantly above speed limits, are you driving in a very haphazard fashion, are you stop and start, are you doing jackrabbit stuff, and to presumably the better driver you are, should result in lower premiums. But people have to agree to have that device installed to be able to monitor these things, to do it. Or should companies pay for employees to have gym memberships right? Or encourage them to do things as a way of reducing their health benefits and costs down the road. But again, you have to have the, the data to back it up.
Yeah.
So I think it's a larger discussion, and it may take, as I say, it's from a system to put heads together and say it's all about, it's about the content. It's about educating or re-educating practitioners to focus on prevention. It's about how they get paid to do X. Do they get paid for prevention? Or is it more heavily weighted towards, treatment, therapy, etc., providing those particular skills? So, any other questions you had? Anything coming from this? Anything that sparked something?
Yeah. I think it was really interesting to hear your perspective and to hear about the work that you're doing. So thank you for sharing.
Okay. All right. Okay. And if you are so interested, so we've had, as I said, we've had a couple of webinars now. We've got one coming up in June, which is going to be on strategic planning and kind of looking at how much change, how much do we, on the next strategic plan, how do you just update it, or do you look at it in terms of, do we need to go full throttle? We need to do a completely de novo approach. And we've got one coming up in July, which is going to be on really incorporating user experience from typically patients, clients, and practitioners, understanding what works, what doesn't work. And it's not all about quantitative data. There's a lot of qualitative research that goes into understanding people's choices and decisions that they make, and what the influences, incentives, disincentives are, and using that to improve service design, program delivery, etc., to be able to make some significant improvements on that. Okay, so that's my pitch for the next things. And if I can be any assistance, your organization wants to, interested in follow up on any of these things, then happy to talk.
It sounds good, Jordan. Have a good afternoon.
Thank you very much. Take care.
You too. Bye-bye.
Bye-bye.